And then there was the epilepsy program, and you know, John Freeman and Patty Vining were just the most wonderful people you can imagine to work with. John had such a wealth of knowledge about pediatric epilepsy and what to do about it. And at one point in 1985, he came to me and he said, "Ben, there's a girl out in Colorado who's having 130 seizures a day. They've even put her into pentobarbital coma for 2 weeks, and as soon as she wakes up, the seizures start up again. What would you think about doing a hemispherectomy, an operation in which you remove half of the brain?" Well, you know, interestingly enough, the first hemispherectomy was done right here at Johns Hopkins by Walter Dandy, way, 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 way back, late 20s, early 30s. It didn't work out the way they wanted, but it had rises and falls, and by the time we were talking about, it had fallen way out of favor for quite some time. But you know, Dr. Freeman had some experience with the neurosurgeons when he was at Stanford many, many years ago, and he thought that this would be a good idea. So, you know, by that time I had developed quite a bit of faith in his judgment, and so we decided to proceed with a hemispherectomy on that little girl. And it turned out to be spectacularly successful. She happened to be quite photogenic, as was her mother. And you know, it was a big spread in the Washington Post. And that engendered a lot of excitement about hemispherectomies. And we were doing hemispherectomies from every place in a very short period of time. And I remember out of the first 14, though, interestingly enough, 13 of them were female. And I remember at a press conference, one of the reporters said, "Why are so many females? Does this only work in female patients?" And, you know, I said, "Well, no, it works in females because they only use half of their brain anyway." But at which time, Patty Vining chimed in and said, "No, no, no, that's not the reason it works. It works because they only need half their brain to be as smart as men." So it worked. There was a touche moment. Of course, I was just kidding. I know women actually use much more than half of their brain. But at any rate, we expanded into lots of different types of surgery beside the hemispherectomies. And much of that work now, John has retired. I don't do seizure surgery anymore. Dr. Jallo, Dr. Vining, Dr. Hartman have continued to work very diligently with the program and moving it to really the next level. But we discovered, but using a lot of the techniques, the gridding techniques, that we could isolate very difficult tumors. In this particular case, this little girl was from South Carolina, and she was having intractable seizures. The tumor appeared to be in a very eloquent area of the brain. We did monitoring and discovered that, you know, all the speech functions really were sort of an anterior region, and the motor functions were back here, and that we could access this area and utilize that to get the tumor out. And to stop the seizures at the same time. So using a combination of the technology that we learned with the epilepsy program and with the neuro-oncologist working together, we were able to do quite a few things. But Rasmussen's encephalitis, I think, is something that really became popularized here at Johns Hopkins because of the vast number of cases that we were doing. This is a CT scan, and you can see how the two sides look quite different. This is the affected side, and there's a lot of atrophy going on there, so it's not so much that those ventricles are dilated. That's sort of an ex vacuo phenomenon. Something has to fill the space as the brain tissue atrophies. And then later on, as MRIs came into place, you can see the fairly dramatic differences between one side of the brain and the other side of the brain. When we first started doing hemispherectomies, that's what we actually did. We took out the hemisphere. So there you see the temporal lobe, occipital lobe, parietal lobe, frontal lobe, all in one big fillet. But what happened is, I guess it was probably about the 7th or 8th case we were doing, and we were taking out the whole thing that way, and it went relatively smoothly, except at the end of the case, the patient didn't wake up, remained in a coma. And, you know, a day went by, 2 days, 3 days. Every time I went by the room, the parents were there grieving over their decision and having second guesses. And a week went by, 2 weeks went by. She used to love Mr. Rogers. So they were always playing tapes of Mr. Rogers, singing and saying poetry. Didn't wake her up. 3 weeks went by, still in the coma, off the ventilator, but still in the coma. Mr. Rogers heard about this little girl, came all the way to Baltimore with all of his puppets to her bedside, tried to wake her up, didn't wake her up. 4 weeks went by. It was 2 a.m. in the morning. Her dad was lying on a cot next to her bed, and she said, "Daddy, my nose itches." And he was just so shocked. He was so thrilled. He jumped up and he ran out in the hallway shouting, she talked, only had on his underpants. And everybody came to see what all the commotion was, and there she was scratching her nose. And that was the beginning of a rapid recovery. In no time, you know, she was walking, she was talking, she wasn't having seizures anymore. Everybody was absolutely thrilled. Then it was time for her to go back to school. Now they began to worry again. She was missing the left half of her brain. Now, how in the world would she be able to do left brain functions like calculating, like math? But she worked so hard, she was so determined that the next year, on a math test, she had the highest grade in her class. And she did that with half of her brain. Now, can you imagine what young people could do with a whole brain and determination? And I frequently use that experience when I go around the country talking to groups of young people to help them to realize how incredibly much potential they have. But one of the things that we started thinking about, the pediatric neuroscience group here, is the whole concept of plasticity. Why is it that these children can do so well? And in fact, discovering that, you know, they're actually able to transfer functions from one side of the brain to the other side. And our pediatric neurology group here really had a lot to do with popularizing that notion. And we discovered that we could use the hemispherectomies not only for Rasmussen's encephalitis, but for migrational disorders like hemimegaencephaly, and even some neuro-oncological problems. This was a young child with a cystic primitive neuroectodermal tumor, and we did a hemispherectomy and followed by chemotherapy. That child actually did quite well for Sturge-Weber disease, for congenital stroke, really for a large number of different types of pathologies. And a lot of the techniques continue to be improved upon even to this day. But you know, I'm very grateful to the people that worked with me, particularly in pediatric neurology, because really it was the hemispherectomies that gave me my first 15 minutes of fame. Everybody's supposed to get 15 minutes of fame during their lifetime. Well, that was the first one. And this is at our first pediatric hemispherectomy reunion. All of these people have had a hemispherectomy. I haven't had one. And Dr. Vining and Dr. Freeman haven't had one. But other than that, they all had them. And this little girl was actually from Baltimore. All the others are from other parts of the country. And this is the little girl I was just telling you the story about, who was in a coma for a month. And this little girl was the very first hemispherectomy. That was the one from Denver, who was having 130 seizures a day. And they all have pretty I could just sort of point them all out and tell you just amazing stories about what happened. Well, another interesting thing that happened the very next year after my first hemispherectomy was I was contacted by the chief of obstetrics at Sinai, Phil Goldstein, because they had a patient who had twins, and one of them had rapidly expanding head hydrocephalus. And it was expanding so quickly that the mother was going to go into premature labor, and they would both be delivered, and of course that would mean death for both of them. And Phil wanted to know, because by that time many people were starting to think that I was fairly radical and that I would do anything, which is not true. But anyway, he thought that, so he contacted me and said, is there a way that you could operate on this child while it's still in the mother's womb, not so much to save the hydrocephalic child as to save the other one? Well, interestingly enough, 3 weeks before that, there had been an article in the New England Journal of Medicine about intrauterine surgery and how we just simply weren't ready to begin thinking about that yet. It was too complex. But here was a situation where, we were really trying to save the other twin. We'd pretty much given up on the one who had severe hydrocephalus. Well, I contacted Bob Brodner in Philadelphia, who was a neurosurgeon there, who had done some experiments on sheep, and in putting shunts into them while they were still in the womb in sheep. And we talked, and he came down, and we messed around a little bit with some equipment and came up with a shunt. We had to do all this pretty quickly, and we had to get permission to do this experimental surgery, which we could not get at Hopkins in that amount of time. There was too much bureaucracy. So we did it over at Sinai. And we actually, with the obstetricians, put in the scope into the uterus, visualized, came up to the fontanelle, pushed the trocar into the brain, into the ventricle, slid the shunt into the ventricle with the other end coming out into the amniotic fluid, and we could actually see the head decompress right there on the ultrasound. And that pregnancy was then able to continue for several weeks until they had maturation of their pulmonary function. And the babies were born. It was a big story. And I remember my brother called me up. He was in another part of the country. He said, I just saw you on the CBS Nightly News. Because there was a big firestorm about the case because of the article that had occurred in the New England Journal, and people saying that, we were hot dogs and, this was a ridiculous thing to do, until it became clear that not only did we save the normal baby, but the hydrocephalic baby was doing well too. After which time they all said, well, I would have done that too under those circumstances. But the whole concept of intrauterine surgery, a lot of people think that, that kind of got started at Philadelphia or at Vanderbilt, but it was actually Dr. Hefes in our department here and Dr. Alex Haller who began to work on actually being able to remove the fetuses from the sheep and operate on them and then put them back in. And they did some of the very signal important work to get that started. And it gives you, again, an example of some of the collaborative efforts that have really allowed the department and the division to move forward. And then the neuro-oncology program. Again, we didn't have a formal neuro-oncology program when I came back, but Bernie Maria was at the end of his training in pediatric neurology, and had also done some work in oncology and was very excited about getting something started. And Dr. Freeman blessed him to really help us put together a neuro-oncology program with a multidisciplinary team. And as a result of that, we started reviewing a lot of very, very difficult pediatric neuro-oncology cases from around the country. And this program continues until today. The multidisciplinary team is much larger now and is spearheaded by Dr. Jallo, Dr. Ahn, Dr. Weingart. Dr. Weingart, I have to admit, has been just a godsend. He trained here, and he went away, left us, and went to Indiana. And fortunately, we were able to recruit him back, and he came back, I think, in 1995, and has always been extraordinarily helpful, particularly with the difficult pediatric brain tumor cases. And then Dr. Jallo and Dr. Honor, again, taking those programs to yet a different level. But this was one of the early cases. This was a kid from Georgia, and he had been diagnosed with a brainstem tumor and had been seen in a number of places. The same diagnosis was given. And they ended up here at Johns Hopkins. And when I first saw the kid, he was on a stretcher, barely moving, barely breathing. And nobody knew, or certainly I didn't think there was anything that could be done about this. But they said, we're at Hopkins because you're at Hopkins. We heard about you. We know you're a very good surgeon. We know you have a lot of faith in God. And we want you to take this tumor out. I said, no one can take that tumor out, this brainstem tumor. They said, you can do it. Well, I said, I'll tell you what, let's get an MRI. So we got an MRI. Oh, well, that's not very encouraging looking either. But because of their tremendous persistence and faith, I said, all right, I'll go in, I'll biopsy it. And I went in and took out part of the tumor, fully expecting him to die because it did come back as highly malignant on the frozen section. We took out as much as we could, and then we started running across vital things, and we said we better stop. And I went out and explained to the parents that, sorry, but we can't be successful at everything. And interestingly enough, he started doing better. I expect him to deteriorate. And I said, let's get another MRI. And this time, you could see a fairly nice plane along the upper part of the brainstem. And I said, is it possible that maybe this was all extraaxial and it was just so big and it was compressing, and that therefore we all thought it was an intraaxial tumor, and maybe we should go back? And they said, by all means. And we did, in fact, go back. And it turned out that it was all extraaxial. We took it out. And after a few weeks, that boy walked out of the hospital. And today, he is a minister. And that family sends a large donation every year to the hospital for us to give to a family in need. It's really a very touching story. But this was another patient who we discovered was in a nursing home in another state. And that is not a hat, that is a tumor. And in fact, along with the plastic surgeons, and this was a 19-hour operation to resect that and to reconstruct his head. And initially the baby actually did quite well and we were thrilled. But after a few weeks started deteriorating, virtually all the organs started to fail. Baby died, and we discovered it had metastasized widely throughout the body. But of course we wrote that case up with photographs and with histological sections, so that obviously if anybody sees something like that again, they're not going to send it to a nursing home, recognizing that really there are things that could be done about it. This was another girl from the South. No one thought anything could be done with this lesion. And this was at the time when stereotactic craniotomies were first being talked about. So we actually did a stereotactic craniotomy. We were able to remove that tumor without causing her any deficits. And it was cases like that that really made people think that I would do anything. But I wouldn't do anything. All these things were very carefully thought out and worked out with the radiologist here, with the functional people here, with the people who had the experience with doing all these different kinds of things. So, none of it was ever just sort of off the cuff. This young boy was from Oklahoma, and he has this large tumor, which was diagnosed as a brainstem tumor. And he had been biopsied at the University of Oklahoma. They had sent him home and said, you got 6 months to live, and that was it. And they ended up here at Hopkins. And of course, looking at that tumor from lots of different angles, it didn't look particularly appealing, but we were able to go in and resect a significant portion of it. It turned out to be a pilocytic astrocytoma, And the interesting thing is the rest of it spontaneously involuted. And that young man I ran into a couple of years ago when I was in Oklahoma. And the family came up to me and said, "Do you recognize this young man who is a junior at the University of Oklahoma?" And I said, "I don't recognize him, but he's a very handsome young man." And I said, "What's his name?" And then they told me, and then I recognized that it was this young man who we had operated on when he was less than a year old. But one of the more difficult tumor cases that I had to deal with actually came in an adult who had Van Hippel-Lindau. It turns out his wife was a nurse on the pediatric neurology neurosurgery service, and he developed one of these hemangioblastomas right in the pons, as you can see. And no one could generate any interest in taking care of this surgically. And so she came to me and she said, "You know, you do all these things. You're going to have to take this out." I said, "Well, I'm a pediatric neurosurgeon. I'm sorry." And she said, "Well, he's a child at heart, so you're going to have to do this." And I said, "You know," and I talked to him, I said, "If we open your pons and we try to take that lesion out, there's a 50-50 chance you'll die on the table." And he said something extremely mature. He said, "If you don't take it out, there's a 100% chance I'm going to die." So given that, we did go in, start taking it out, and interestingly enough, while I was pulling on the capsule of the tumor, the evoked potentials went flat. And that, of course, was very disheartening. We finished the operation, closed up, but we weren't very excited. But the very next day, he had already been extubated and was up cracking jokes. And so it's amazing the kind of things that happen. But perhaps the thing that I'm most known for is separation of conjoined twins. And this is actually a picture that comes from the Corpus Scriptorum Historiae Byzantinae, the written history of the Byzantine Empire, 1,000 years ago, depicting the first successful separation of conjoined twins. Two boys joined together at the umbilicus. It's not a very good depiction. And one of them died. They were in Constantinople, and surgeons of the day separated the dead one from the living one, who survived for 3 whole days, considered a great medical triumph at that time. But you know, I got interested in conjoined twins early in my career, started reading a lot about them, trying to figure out why the neurosurgical interventions were so devastating, and concluded that it was exsanguination or bleeding to death. And you know, I was talking to Bruce Wrights about how they do the pediatric cardiac surgeries, and he was telling me about the hypothermic arrest that he'd done some work with. And lo and behold, a couple of months later, here came these German doctors to present the case of the Bender twins. And there you can see their mother, Teresa, and the Bender twins themselves. Very extensive joining, occipital craniopicus. Such twins had never before been separated, with both surviving. And she had been told in Europe that she had to choose which twin would live, and that they would just cleave whichever one she didn't want off. And she just couldn't make that choice. So they were looking for somebody who had a solution. And I started talking to them about, you know, separating them and using hypothermic arrest at the appropriate time to be able to do the operation. And we started putting together a team here. It was an amazing team. Mark Rogers, who was the chief of pediatric anesthesia at that time, was just masterful in orchestrating the way that it was all put together. And there you can see the twins. Some of us actually went over to Germany to look at them, to put in scalp expanders so that we would have skin to cover over at the end. We discovered some things that we weren't expecting. For instance, you see the vertebrals and the basilar systems, how they actually joined. And we were saying, well, how in the world can you separate that? Well, you know, that was a major risk we actually took when we separated. When we put clamps on it and we cut it. And But there were some very substantial problems. There you can see the team operating. We got into bleeding much earlier than we had anticipated. We would only have 1 hour of hypothermic arrest time, and we had to go on hypothermic arrest much sooner, and that really changed things. But on hypothermic arrest, this is one of the venous sinuses. Normally there's blood flowing through there at a high rate. There's nothing there. Cold, pulseless. It's like operating on a cadaver, but operating extremely rapidly in order to get things reconstructed. And Dr. Reitz and Dr. Cameron were actually looking over our shoulders, and they were cutting out pieces of pericardium from the heart that were just the right shapes for this, for various other things, so that we wouldn't have to waste time sewing them back together. And we asked people, don't tell us how much time there is left, because we didn't need the extra pressure. And we finished at 59 minutes and some seconds. As we started pumping the blood back in, you could see there was a lot of hemorrhage. Things started swelling. It was really quite monstrous. But in the long run, they did okay. You can see that they were not suffering nutritionally at that point as well. And then, you know, a few years later, there was another similar case in South Africa. But they were very, very rapidly deteriorating. And, you know, they summoned if I could come over and help. And we actually did exactly the same operation. But when we went in to put them on hypothermic arrest, discovered that one of the hearts was just not functioning. It was just fibrillating. And the other one was doing all the cardiac work. And that's the reason they were deteriorating so fast, because as they grew, the one heart could not do all the work. And they were going into failure. So we got them separated. The one with the good heart actually was doing quite well for the first couple of days, and then started seizing and eventually died, and it turned out that that one had no kidneys. The other one had the kidneys. So, you know, they were symbiotic in that sense, and really points out the importance when you have twins of that nature to really study them extremely carefully. And that's those. And then a few years later, there was another set. These were from Zambia, but they were going to be done at the Medical University of South Africa. I was a little weary about whether I should go back again, because I was still licking my wounds from the one before that, and saying, well, if I go back there again and get involved and they fail, then I would have failed 2 out of 3 times. I don't know if my ego can take that. And then I said, wait a minute. It's not about your ego. It's about whether those kids can have a normal chance at life. And I said, you should never, ever think a thought like that again. Because of all the gifts and talents that we have as physicians, we can never let ourselves be co-opted by ego and co-opted by peer pressure. We must always remember that our first obligation is to the patient, no matter what the outcome. But the interesting thing in studying these, you can see that this common circular sinus is in one phase of the venogram not full. And that said to me that they probably had the propensity for developing collateral circulation relatively quickly. And that we could in fact separate them and cut through that circular sinus, which has always been the thing that has bugged people about that kind of surgery. There have been 13 attempts to separate type 2 vertical craniopicus, which these two were before, without success. But by concentrating on that area and doing the separation, and the other thing that was a tremendous advantage is we have a 3D workstation over in the outpatient clinic. And I was actually able to drive through all those vessels and practice the operation before actually going over there. So I knew which vessels went to which twin, an enormous advantage. And after a 28-hour surgery, they actually turned out quite well, and they're actually in the 8th grade now. But perhaps the one that garnered the most attention around the world was the Bijani Twins. And you know, they were 28 years old. Women from Iran, their lifelong goal was to be separated. And they scoured the world looking for a team willing to do that. And when they first contacted me, I told them about Chang and Ing Bunker, the original Siamese twins who lived to be 63 years old, never got separated, but they didn't want to hear that. So they ended up with a team in Singapore, and it was a team I had worked with before on some other twins, so somehow they managed to convince me to come and help them against my better judgment. But when I saw those twins, I was just flabbergasted. They were full of personality, they were vivacious, they were smart. They learned to speak English in only 7 months, if you can imagine that. They both had college degrees. They both had law degrees. Only one wanted one, but they both had law degrees. So, you know, they were incredibly intelligent. They understood, you know, the risk that they were taking. And they said something to me that really struck me. They said, "Doctor, we would rather die than spend another day stuck together." And I realized, you know, putting myself in their shoes, what it must be like not to be able to get away from somebody for 1 second when you have different goals and aspirations. Well, that operation went on, and we were about 90% finished. And some people were starting to celebrate. I was not among them, because when we got to the very end of the operation, they began to bleed profusely under such force you couldn't stop it. And they exsanguinated. But there were a lot of things that we were able to learn about adult circulation in that. And these are just some of the models that are used to help study the anatomy in these kinds of twins. But, you know, this is the last case I want to mention. And these were, again, twins from Germany, type 1 craniopithecus, Leah and Tabia Block. And the thing that was absolutely fantastic about this case is, you know, I come to the understanding that our neurosurgical department is the most talented neurosurgical department on the face of the earth. And everybody is extraordinary at something. So we actually put together a team composed of the members of our department. Just about everybody was involved. And everybody slotted in when we came to the part of the operation where they were the world expert. And we were literally 10 hours ahead of schedule by doing it that way. And what that really points out is the incredible strength that can be derived when you have general excellence that is willing to work together. And that is a theme that I have learned here at Hopkins, but I think it is a very important theme for our nation as well, because, you know, we have so much division in our nation. You know, Republicans don't like Democrats, Democrats don't like Republicans. A wise man once said, "A house divided against itself cannot stand." And that's why, you know, for the last several years, and for the many years, hopefully, to come, I'm going to devote an enormous amount of energy to trying to help our nation to heal, and to recognize that, you know, we all have talents, we all have thoughts, we have different ways of doing things, but that doesn't make us enemies. And if we learn how to use that in a thoughtful way, what a tremendous advantage it will be to all of us. And, you know, in medicine, there are enormous advantages that accrue to us in working with children and working with adults and being able to restore them to health. As an intern, you know, when I came here, I was so impressed. I saw all these important people, crown prince of this nation, the king of this place, CEO of this organization, president of this, dying of a glioblastoma. And, you know, every single one of them will give them every title and every penny for a clean bill of health. And, you know, what we get to work with is the most important thing that a person has, and that is their health. There's nothing more important than that. And it doesn't have to be a newsworthy case, because it's newsworthy for that patient. It's newsworthy for that family. And I get asked the question all the time, what's the most memorable case you've ever done? And I always say, that's easy. It's the last case that I just did. And it's always memorable when you get to go out and you get to tell that family that their loved one operation was a success and that they're doing well. And there is nothing in the world that is better than that feeling. And those of us who are surgeons, you know, we get a lot of credit for what we do, but I just want to point out the fact that none of us operates in isolation. There's always a whole team of people without whom we could not do what we do. We could not do what we do here at Johns Hopkins without the nurses, the technicians, the administrators, all of the people who have a single focus, and that is providing the best care possible for people. And, you know, I hope I continue to have a long life and have an opportunity to do many things. And you know, last month my wife and I had an opportunity to go to New Zealand. And what a thrill it was to walk into the largest venue that they have in the country and have it filled with thousands of kids who were cheering and just, you know, yelling my name. They were so enamored with the story. And in less than 2 months we go to South Africa to do the dedication of a medical school that's been named after me. And we were recently in Detroit for an inauguration of a high school named after me. And next month I'll be in Atlanta to give the commencement at Emory, and then I go to another school that's named after me there. But you know, all of those are wonderful acknowledgments of the effect that one has had. But of all the acknowledgments, of all the accolades, of all the honors, the greatest one I've ever had is being able to work here at Hopkins with so many great people. Thank you.
Wow. That wasn't in any sense a lecture, as far as I could tell. Absolute tour de force. So thank you in every respect for all of this. And the inaugural lecture will certainly go down as one that's hard to top. I do want to thank, on behalf of the department, on behalf of Dr. Carson, Dr. Brem, and others, several of the other chiefs who are here today who have worked tirelessly to help create this culture, this interdisciplinary culture, this culture of creativity. I can't see up top now, but Dr. Dover was here, Director of Children's Center and Chief of Pediatrics, obviously a significant support for Dr. Carson's work. Peter McDonnell is here, who's Chair of Wilmer. Alan Parton, Chair of Urology, and David Eisel, who's Chair as well. And really, what an evening. We have been rewarded to this incredible lecture, and my personal reaction is that the lineage of Harvey Cushing lives certainly in the groundbreaking work of Dr. Brem, Dr. Q, certainly Dr. Carson, who is the focus today, and the absolute who's who of neurosurgeons that have been assembled at Hopkins. Clearly testimony to the incredible power of intellectual pursuit and the ethical command of medicine in service of humanity. Remarkable stuff, and thank you for all of you for filling our afternoon with this wonderful insights. Every aspect of your professional lives at Hopkins have been devoted to patient care, and your clinical work, your research are designed to clarify conditions and diseases and to develop treatments that are applicable worldwide, and the scope of your impact, the scope of the community of doctors at Hopkins impact is truly amazing. We hope that all of you will continue to come to know these lectures as a milestone during the course of a year or beyond, and share with us and with the department the excitement of pushing forward the boundaries of what we can do for the patients at Johns Hopkins and those around the world. So with that, thank you very, very much for coming, for attending the inaugural Harvey Cushing Lecture. Dr. Carson, for enthralling us with your words and your deeds, and to all a good evening. Thank you.